So thank you, Dr. Barnsteiner, for that thoughtful opening session for us. So good afternoon. My name is David James. I'm a member of the Planning Committee, and I'm currently serving as a Nursing Professional Development Specialist and an adjunct instructor at the University of Alabama at Birmingham. I'm a QSEN enthusiast because of a quote I read several years ago by Dr. Berwick in 1988, who said that healthcare has developed a very long leg for measurement and a very short leg for managing change, and therefore is walking in circles. And I don't know about you guys, but I'm tired of walking in circles. So it's my pleasure to introduce our next speaker, Dr. Ann Sales. Dr. Sales is a professor and associate chair of educational programs and health system innovation in the Department of Learning Health Sciences, University of Michigan Medical Center. She is also a research scientist at the Center for Clinical Management Research at the VA Ann Arbor Healthcare System. Her training is in sociology, health economics, econometrics, and general health service research. Her current work involves theory-based design of implementation interventions, including understanding how feedback reports affect provider behavior and the role of social networks and uptake of evidence-based practice interventions. She's editor-in-chief of the Journal of Implementation Science and is regarded as an expert leader in the field of implementation. Dr. Sales will help us to understand how implementation strategies can be used to facilitate the implementation of QSEN competencies in both academia and practice. Please join me in welcoming Dr. Sales.
It's a real pleasure to be here today, and in particular because I actually have had the pleasure and the privilege of using the QSEN competencies in a course with graduate students at the School of Nursing at the University of Michigan. And I have to say that I stumbled somewhat as I was using those competencies, so I found myself not entirely sure all the time how best to convey this really vital information, even to graduate students. And of course, most graduate students in nursing have years of experience. They're typically not straight out of undergrad, although increasingly we're seeing more and more people take a route that comes more directly out of undergraduate education. I think the challenges ahead of us, even though I think Jane's points about the fact that the dissemination across academic nursing and nursing education has really accelerated in the last several years. I'm sure those are all true, but figuring out how to actually make these things real in practice and real for people coming out of our educational programs is really where the next challenge lies. So I'm going to spend some time today talking about some of the more theoretical pieces around implementation science, although I'm going to try very hard not to go into the weeds too deeply. I can spend a lot of time in weeds on implementation research. But I would like to say that there is a workshop tomorrow. I think it's in the second concurrent sessions when I will, for those of you with interest in this area, be happy to spend more time talking in much more detail about some of the things I'm going to touch on pretty lightly today. So I want to just start off and say I don't have any conflicts to declare, although being a co-editor-in-chief of a journal actually is a little bit of a conflict for almost anything you do, because there's always the potential that what you're going to talk about is something that the journal has some piece in. And also just to say, increasingly, journals are published by for-profit corporations that have at their heart, not necessarily scientific interests. It has much more to do about money. And so that, again, also creates a certain set of conflicts. On the other hand, I have to say, I think that I'm not terribly embedded in these conflicts, so I think it's still fair to say that I don't have any to declare. But I also wanted to say that I was asked to talk both about dissemination and implementation, and I am going to just flatly acknowledge right now that I probably won't do much talking about dissemination. That's because that's not really my area of expertise. But I did find an interesting resource, which I've put a link to, and my slides should be available for all of you, so you can follow this link easily, from the United Kingdom, with some really interesting, innovative ways to think about dissemination, particularly in education. So I wanted to offer that to you and suggest that you might want to look at those as another way of thinking, perhaps, from a different country, a different culture, about ways that the work that QSEN is doing can be disseminated. I'm going to be talking more about implementation, though, and starting off with just definitions and talking a little bit about why implementation and the science, the emerging science around it might be of value. So very briefly, I'm not going to spend a lot of time on this. The discussion around implementation has often been married to dissemination. The two are not completely separate from each other. But I would argue that dissemination is a necessary but not sufficient condition for implementation. If material hasn't been disseminated and people are completely unaware of it, and we've heard a little bit that perhaps there's still some lack of awareness as part of the problem that may underlie the lack of implementation in this area, then it's very difficult to implement. But getting things disseminated, getting materials into people's hands, putting things up on websites, no matter how good those websites are, is seldom sufficient to actually get them to change their behavior. And that really is what implementation research is all about. I would argue that it is really the science of planned human behavior change under organizational constraints. And I will say very clearly that part of the reason I see the world this way is because I am a nurse. A lot of my colleagues in implementation research are physicians, and they do not always see the organizational constraint part of this definition. Eventually, they come around to recognizing that there are organizational constraints, and they talk about them a little bit more. But it's not natural for them to think about those things. For us as nurses, it is very natural. We are almost always employees of organizations. There are nurses who are in independent practice, there are nurses who own their own practices, but they are very, very small in number compared to the vast majority of nurses in this country and globally who work in organizations, and increasingly in complex organizations doing complex things. So this definition, I think, is highly relevant to nursing, and it's relevant to nursing education as well as to practice of nursing. So I'm going to say right now that I'm going to try and sort of talk about both educational implementation and practice implementation, but my work has been in practice implementation primarily. So many of you will know much more about the implementation in educational settings than I do. I also want to say that implementation science or implementation research is a really rapidly evolving field. And one of the places where it's been evolving most rapidly is really in this understanding that it is about behavior change. So it isn't necessarily just about what some of my colleagues, if you look at the definition in the upper left-hand side of this particular slide, talking about the study of methods to promote the systematic uptake of research findings and other evidence-based practices. It is about that, but what that actually means, because it's easy to say uptake, but what uptake means is people change their behavior. They change the way they're practicing. And I just want to go back to Jane's slide around those particular evidence-based practices that she cited, and the really alarming amount of lack of knowledge that we have as professionals in this area, that we don't necessarily know the right way to ensure that the nasogastric tube is in the right place. That's a fairly frightening thing, because NG tube placement is common practice, and if it ends up in the lungs instead of in the stomach, it is a really bad thing for people. So understanding something like that, which is not a simple procedure, but a common and frequent procedure, is really important. And the behavior of what you do when you place an NG tube is really an important piece of behavior. But I also want to stress that we do this in context and within organizational policies and cultures. And one of the things Jane cited in her discussion of what people go to when they do try to understand what they should do when they place an NG tube, they go to their policies and procedures. And then there's the question of, are these evidence-based? Are they updated? Are they current? Do people know where to find the policies and procedures under which they're supposed to be practicing? And do they understand the degree to which those should guide their behavior? All of those are pretty open questions, and all of those reflect the organizational constraints that people operate under. I'm not going to spend a lot of time on this, but I just want to say very briefly, because there's frequently a discussion about the difference between quality improvement, sometimes called improvement science, and implementation science or implementation research. And I just want to really make the point, these come from different traditions. So implementation science comes out of the evidence-based medicine movement, and I do mean evidence-based medicine in this particular case, in the 1950s, following World War II, when Archie Cochrane, who was a physician and an epidemiologist in the UK, asked the question, how much of what we practice in medicine has any basis in evidence? And the answer that he came up with was about 30%. And that was a shocking idea to people in the UK and globally, that this practice of medicine, which people believed was highly scientifically based, in fact, very little of it could really be shown to have a strong evidence base. And this spawned a really intense, ongoing movement to try to understand the evidence basis for the care that's delivered by physicians, and increasingly the care that's delivered by healthcare professionals in general. So that's one place that implementation research comes from. Coming out of this are systematic reviews, meta-analyses, guidelines, which have been particularly embraced in medicine, but increasingly embraced by other healthcare professionals as well. I would argue that health services research in the United States and globally was another contributor to implementation research as it has evolved, and in particular the studies of variation in practice, because it's easy for people to think that everybody does what they do. But in fact, when you look across organizations even, you find that the differences in practice among units can be striking. And when you go across regions of the country, you find that in fact, people don't practice the same way in different places. So it may be common, for example, to do radical prostatectomy in one region of the country for uncomplicated local prostate cancer, and in other parts of the country, no one gets a prostatectomy unless they have some evidence of metastasis. Those are really different things which have huge effects on patients and on their well-being. Outcomes research has also been a contribution from health services research, and one that I have to say has been not always very well understood. What constitutes an outcome? Why do we study outcomes? How do we study outcomes? Is still an evolving set of issues. And I think within nursing, we have a way to go to try to embrace the idea that outcomes matter and figuring out how we measure our own outcomes. And then finally, just in this very quick overview of the history of implementation research, the most recent contribution has come from psychology, in particular health psychology. And this has been the contribution of the theoretical approaches that really have to do with human behavior change. And they come from roots of behavior change among patients. So for example, lifestyle change and other things like that. But translating this into how we as providers behave and what it takes for us to change our behavior in the care that we deliver to people. Quality improvement comes initially from work done between and after the Second World War, focusing on manufacturing and quality processes in manufacturing. And I would argue that that is a very different route from asking the question, how much of our care is based on scientific evidence? It is about standardizing care, and it's about ensuring that at least a floor is being met in terms of quality and somewhat to the same extent safety. And this is one of the complicating discussions about whether quality and safety should be in the same discussion or not. I happen to think they should, but it's debatable. So it's important to think about these as different things that both can try to achieve the same ends, but do them in different ways and focus on different aspects of the problem as they are engaging in those. So I'm going to leave that topic then, but again, happy to discuss it more during the workshop tomorrow. So why do we worry about implementation, science implementation research? Doesn't everybody who provides healthcare just do the right thing? I'm going to assume that everybody in this room would say yes, absolutely. So this is something that I'm sure is really familiar to all of you, and Jane alluded to it. And it's very interesting to see that the American Journal of Nursing has been publishing on this issue for over 100 years now. And if we go back to Florence Nightingale, in nursing, this has been one of the central issues that we have that founded nursing as a profession and as a discipline. The fact that, indeed, infections are transmitted by human contact, and if we are not diligent about how we take care of our own persons and the things around us, that we then become complicit in spreading infection. I'm saying much more than the 5 moments of the WHO, but I suspect all of you know what those are. So this is just a graphic representation of the same thing. A patient lying in a bed, we're the ones circulating, we're the ones who, if we're not careful, are spreading infection. So this has actually been a topic in implementation research and quality improvement for a long time. Not quite as long as AJN publications, nor certainly Florence Nightingale, but it's been a topic of research. And frankly, it is an ongoing and persistent failure. We have not succeeded in eradicating poor hand hygiene. And I honestly don't believe we will in my lifetime, even though there have been some incredibly innovative things done that have to do with engineering solutions, that have to do with persuasion and building trust and building relationships. The reality is this is a very hard thing to do. And it's hard in the moment as well as in the broad context of what we do. But when we think about wanting to make change and wanting things to improve, we often really do think and want a magic bullet to be available to us so that we can implement anything, anywhere, anytime, with any group of people, do it reliably, do it over and over again, and do it efficiently and cost-effectively. And I have to say that one thing that has become very clear through implementation research is that there are no magic bullets. This first paper was published in 1995, which is getting further and further back in the rearview mirror, even for some of us who like to think we stay young. And then 9 years later, the next paper using this title got published, and we are really ready now for the next paper, which will be more than 10 years after still no magic bullets, where we have to say, really, still no magic bullets. There aren't going to be any. And that's part of what makes this difficult, because when people go into implementation research and improvement science research in general, they really, in their hearts, are searching for the magic that's going to make this work. So I'm not going to repeat the definition here, except to say it's a complex and long definition. And it can be shortened, you can make it simpler, but it doesn't make it any more difficult to do. So this is not a quick trip down the highway or a quick stop in a convenience store. This is a long marathon that people really have to sort of engage in. I think that's true of the QSEN competencies as well. This is something that hopefully more will be achieved soon, but at the same time, it's going to take long time, and probably most people's careers and lifetimes, to get it really embedded thoroughly into practice and into education. So I'm going to very quickly talk about evidence-based practice and its definition. This one, there are many different definitions of evidence-based practice, and it is a contentious term. So I'm just going to acknowledge that and say that this one, to me, speaks more to what I think the issues are. And it actually speaks to the issue of willful blindness that Jane raised, because it starts off by saying that it is the conscientious use. So this is a matter of internal decision-making, your own conscience, making use of current best evidence in making decisions about patient care. And this comes from David Sackett, Sharon Strauss, and other colleagues mostly in Canada at McMaster University, but other places, where they have spent time really thinking through what is this evidence that people are trying to move into practice and trying to use in practice about. So I just want to note that this incorporates professional expertise, best research evidence, and also client-patient values. And Jane has spoken to that very eloquently. This is something we can't let go of when we talk about evidence and science. This is an important piece of the evidence that particularly we as nurses bring to the table, but increasingly is being recognized as important by people globally and in our own settings. Most of you have seen the evidence pyramid. I'm not going to belabor it except to say that this is part of what people contest a great deal, because it really does say that unless you have synthesized the evidence and unless there's a body of literature to synthesize, you may not be engaging in evidence-based practice. You may not know what the evidence is. And that is an inherently long process. It is not a quick fix. So I just want to note this because many of my colleagues, particularly in my department of Learning Health Sciences, really do believe in their heart of hearts that if we can just harness data and make data more malleable and do things with it faster, that we will achieve insight much more quickly. And I think we probably can speed that up some. But I also think the lessons about synthesis are very important, because if we also try to move things into practice too quickly before we achieve synthesis and before we know more about the impact of innovation, we may actually be doing damage. So systematizing what we do is really at the core of implementation and the science around implementation. We need to have consistent principles for designing interventions, and I will talk briefly about implementation intervention design. They need to be based on evolving knowledge and standards which keep evolving even though we would like to stand still and have a chance to breathe for a minute. This is more about being rational and replicable than simply using intuition. And I think this is actually a challenge for us as nurses. I feel it in myself at times. I'd like to just be able to use my intuition and my expertise. This is part of the novice to expert journey that all of us have been on. That once you become expert, you want to use your expertise. But sometimes you're wrong. And that's the really difficult part. It's not easy to discern when you're wrong from when you're not wrong. So one of the things that has frankly been a real problem in implementation research until fairly recently is that we've been using something called the Islagiat principle. Does anybody have a guess as to what that stands for? It's not an Icelandic term, I can promise you that. Right, very good. Very close. It seemed like a good idea at the time. And I don't know about all of you, but if you haven't had to say this several times in your practice world, then you're much better practitioners than I am. This is just part of living, that we do things and we test things out, and some of those things don't work. And I think that the slide that I think it was Mary used that says we have to learn from our failures, don't waste a good failure, is also an important piece of this as well. That failure is not a bad thing, but if we don't learn from it, it really is a wasted opportunity. Okay, I'm going to shift gears now and start talking much more concretely about implementation strategies. Up till now, I've really wanted to just set a little bit of a stage for kind of where the thinking is in the field, where people are going, and how it is to some extent different from some of the other very, very real trends that are out there and that are important in our healthcare system. So there's a lot of dependencies in implementation research. Many things depend on a number of factors, and it's something that you'll say a lot and think a lot and hear a lot. So one question is, what is it that you're trying to implement? What are the things that you're trying to get into practice? And this gets back to the definition I used of evidence-based practice, and I'll just say, this has been discussed many times, and there's general consensus by most people that synthesis is probably the best place to start from, that single studies are not a good idea for pushing hard into implementation. Having said that, though, we see it all the time. A good idea, what seems at least like a good idea at the time, gets pushed forward by passionate people who are advocating for it and usually have very good reason to be passionate advocates. And I'm just going to say here, barcode medication administration in the VA, which started in the early 2000s, was for many years a really good example of this, because it came out of a single VA facility, and the for those of you who work in the VA, you know that the saying is, you've seen one VA, you've seen one VA. So it came out of a single, relatively small VA facility designed by a pharmacist who looked at the problem of medication administration errors and said, you know, part of this is just we're not standardizing the way that we identify patients and identify medications and make sure that the right medicine gets the right patient at the right time. So if we just scan everything, it will go so much better. Well, I can tell you that for at least 5 years in the VA, it made nothing go better. It was implemented very quickly without sufficient guidance, without sufficient planning, without really the right materials at hand. And what it created for nurses was an incredible set of headaches that meant that meds were typically delayed by up to hours at a time because of the workarounds that had to be done, the amount of time and effort it took to actually get these things moved into practice. Having said that, after the first 5 years, with a number of very, very good studies by human factors people and others, the VA did actually fix issues and started to make the system much more workable. And I'm not sure anybody would say that BCMA within the VA is necessarily one of its crown jewels, but I think people would say it's functional. And it probably does eliminate some kinds of errors. So there's value in that. But there may have been more value, potentially, in having multiple studies to actually see what the problems might be, what would be coming up if you moved it from one site to another and then to a few more, studying what happens as you do it. And so that's a really core piece of thinking about implementing, that it is about planning and it is about not making assumptions that because it works in one place, it will work somewhere else. There's a real issue about to whom are you transferring information? And often we think that we're transferring information to people just like us. But the reality is there aren't a lot of people just like any of us. We're all different enough from each other that even the translation or transfer of information among groups within relatively homogeneous groups like this one are still complex. But when you start transferring information to really different audiences, like consumers, like family members, like physicians as opposed to nurses, pharmacists, social workers, community and lay health workers, people with less professional education, all of these become very complex targets for the dissemination and implementation of information. It always requires planning. And this is typically where the first failures start, that we don't plan enough and we don't plan well enough. Knowing the audience that you're planning to try to transfer information to, and I should say this, the paper that these comments are based on comes from Canada, where the term implementation research is not used commonly. Instead, the term is knowledge translation. So that's why this emphasis on transfer of knowledge. Identifying barriers, which I'm going to talk more about in a couple of minutes, and then using those barriers as you identify them to think about change strategies. Again, this is really all planning. So this is part of what makes people frustrated about using implementation research principles in practice, that it takes a lot of upfront work. And I can't say that it's always worth it. Because we still fail, even when we do all of the things that I'm talking about. But at least we fail less often, and hopefully a little bit less spectacularly. Though, again, I'm not sure we have evidence that really says how much less spectacularly we might fail. But one of the pieces of evolution that's happened in the last few years is to begin to actually catalog change strategies. So I'm going to talk about some of those for a few minutes. And this is probably completely unreadable to all of you since I can't read it very well from up here. But I'll talk through it. So part of the issue is that not all strategies that you could use are equal. And one of the things I want to say is I'm not going to talk a lot about innovative strategies. I think there are innovations in change strategies that are out there that need to be tested and need to be tried. But for the most part, I think it's good to start with strategies about which we know something. So we actually have systematic reviews and meta-analyses on all of the strategies listed here, which include printed educational materials, which is going to sound very, very old school to people. But on the other hand, it's still most of what we do. We still mostly print things. And even if it's up on the screen instead of on paper, it's still the same thing. It is a flat push out of information to people, and to people for whom you don't know who they are, who are receiving this. Educational meetings, which are a step up probably from printed educational materials widely disseminated, because at least at educational meetings, in theory at least, you've got people in the room and you can interact with them. But I have to say, how often do we do that? And I've been at a couple of continuing education sessions with physicians. You know, it's the sort of classic evening kinds of meetings. And as soon as the lights go down and the slides start, half the room's asleep. And that's probably true of nurses as well. We're a little bit more compulsive, typically. So more of us would probably stay awake. But the reality is when you're sleep deprived and you've just been fed and the lights go down, you'll probably fall asleep. So educational meetings, if that's how you're going to use the time, are probably not going to be much more effective than the printed materials that you'll also hand people as they walk out the door and hope that they actually look at it later. Educational outreach, yet again, one step more assertive and active with people, where you actually sit down with one-to-one or a small group of people and talk through issues. This is probably best known as not academic detailing, pharmaceutical detailing, which has been used very effectively by the pharmaceutical industry to make contact with and persuade physicians to use products that they haven't used before, or to use more products that they are using but not in the quantities that the pharmaceutical companies would like them to use them in. Opinion leaders is actually a very different strategy, and I'll just say that's beginning to get into the social networks and trying to influence people through existing social bonds as opposed to creating bonds through much more diffuse contact like educational meetings, educational outreach. And for those of you who can come to the workshop tomorrow, I would love to talk more about opinion leaders and nurses, because the evidence is that opinion leaders work quite well for physicians and work very poorly for nurses. And I think there are a whole lot of reasons for that. Audit and feedback, which is frankly, and I'll just say personally, my favorite and to me the most important strategy we have has been studied, some people would argue, to death, and yet despite 140-some randomized controlled trials, and not to mention lots of other studies that used non-randomized methods, we still don't know how to create feedback reports that are effective, that actually hit their target, and get people to change behavior. And then there's the whole area of using electronic health records, which is a huge growth area. Computerized reminders are a big piece of this. One of the issues is we don't remember everything we have to do all the time in an increasingly complex world with lots and lots of people to take care of. So having some kind of reminder is very useful. I suspect all of us use these in our personal lives, at least to some extent. And then finally, tailored interventions, which is frankly just a whole sort of grab bag, where the idea is that tailoring is about overcoming the barriers that you assess. So I'm not going to spend more time on this, and I'm not going to go through all of the different effect sizes, but I will say the effect sizes are not comparable. So some of these have been shown to be much more effective overall, on average, than others. But on average doesn't mean that it always works, and I think this is a really important piece of information. And also, the effect sizes for any of these are at best moderate. So this is just a piece of reality. We don't have anything like a bullet. We have maybe sort of like a wadded up piece of paper that you throw at people and they go, ooh, did I feel something? That's more like the effect that we're having. Okay. And then just to sort of put this to rest, because this is actually one of those interesting things that got wide publicity. My colleague Jeremy Grimshaw, who's very well known, is at the University of Ottawa and Ottawa Hospital Research Institute, published a paper in, I think, 2004, where they had done a meta-analysis looking at when you use multiple strategies put together, so multifaceted strategies as opposed to single strategy. And in that analysis, they actually found that multiple strategies, multifaceted strategies, were more effective than single strategies. However, they went back and redid the analysis because they realized they weren't entirely comfortable with it and discovered that, in fact, they were wrong. But the message about multifaceted strategies has stuck, and people really believe it, despite the fact that Jeremy himself says, please don't believe that. We redid everything, and we were wrong. I'm sorry we were wrong. But for whatever reason, people find that paper and not the subsequent papers, like the one that I'm citing here from 2012, where they say, no, actually, it's not clear. It depends. Sometimes single strategies are more effective. And I will just say the thing I think it depends on the most is whether you're hitting different targets and different levels, organizational levels, when you do more than one strategy. Many multifaceted strategies simply hit the same target with just a bunch of different ways of doing it. And they're often things like 3 different ways of doing educational outreach, as opposed to really being multifaceted and hitting different targets in different ways. That, you would imagine, probably would be more effective if it's targeted well, but it's also a lot more expensive. Okay, so that gives you a little bit of background about the strategies that we have and the way that we're beginning to think about having approaches that we have some knowledge about, some evidence about. I'm going to talk a little bit about frameworks because this has become, for many people, the hallmark of implementation research. And on a personal level, I find myself frustrated about it increasingly. So in 2012, Rachel Tabak, who's a colleague at the Washington University in St. Louis, and other colleagues there, did this very, very nice systematic review of all the frameworks that are out there, well, most of the frameworks that are out there in the implementation and dissemination literature, and decided that 61 of them really were implementation and dissemination frameworks, and cataloged them in this very nice paper published in 2012. They also looked at whether they were individually focused, organizationally focused, or socially focused, which is a very helpful thing. As I was just talking about, this notion of different levels is one of the things that probably does matter with multifaceted strategies. And then they ended their paper by saying, well, you know, here's a whole bunch of frameworks. Just pick the one that seems to make the most sense to you. And frankly, for people who are learning implementation and dissemination approaches, for people who are even have been using them for a long time, this is not terribly helpful. And I'm going to just assert that not all frameworks are equal. Some of them are consolidations of the literature, so they actually are meta-frameworks. They include lots and lots of other frameworks. And others are single study frameworks that were developed for a very particular purpose and may have had resonance for that particular purpose, but they don't necessarily transcend the purpose for which they were created. Okay. But one of the things that I've been struck by is that in 2015, which is now 2 years ago, Per Nilsson in Sweden actually wrote a very nice paper, which was published in Implementation Science, saying there's really a typology. These frameworks are not all equal in that they don't all do the same thing. And this is actually a really important issue. So what he talked about are 5 different types of frameworks, and I'm really only going to focus on 3 of the 5 because the other 2 are both theories, and I honestly don't think we're at a point yet in implementation research where we can use theories constructively. So he talks about process frameworks, which are really descriptions of how you do the process of implementation and how you would do that planning and then enact the strategies that you come up with. And then there are determinant frameworks, and these are really the place where most of the consolidation of the literature has taken place, which is trying to understand what factors affect the probability that your implementation will be successful or not. So I would argue these are very important. Process frameworks are also important, but they're in a much more sort of global sense. Determinist frameworks are really important, and I'll explain more in 1 minute about that. And then finally, evaluation frameworks. And some of these are the ones that people know the best, particularly in the US. So RE-AIM, for example, Reach, Effectiveness, Adoption, Implementation, and Maintenance, which was published by Russ Glasgow 25 years ago, is one of the best known frameworks in implementation research, but it is an evaluation framework. You could also use it as a process framework to some extent, but not really. It's an evaluation framework. So using it to plan an implementation project is not all that useful. But it's very useful for evaluating what you're doing. So I'm just, again, I'll go into much more depth on this in the workshop, but I just want to say this is one of the things that has complicated and confused people for many years now, that we have all of these frameworks and nobody knows what to do with them, other than if you don't have one of these in your proposal, if you're going for national funding, you will not get funded. That message has come across very clearly, which has led to a proliferation of people just grabbing a framework, sticking it in their paper, and saying, I've got a framework. It's not terribly satisfying. So I'm going to talk very quickly about determinist frameworks. And just to say, there are many different determinist frameworks. We haven't yet actually done the work that I'm now thinking 2 years later we should have done it by now, but hopefully we'll get it done soon, of classifying all of the frameworks into this typology that Per Nielsen put together. So many of these determinant frameworks will be quite familiar to people who've done any reading in the implementation research world at all. Tricia Greenhalgh's really landmark work that was published in Milbank Quarterly and then much more readably in a book in between 2005 and 2007. Susan Mickey's work in the UK. Susan is a health psychologist and the leader of a group of people that have been developing the theoretical domains framework, which consolidates something like 33 different theories of human behavior change. The work that Laura Damschroeder and other colleagues at the University of Michigan did in 2009 and moving forward on the Consolidated Framework for Implementation Research, which fondly known as CIFR, but largely built off of the Greenhalgh's work with some additional components. And then most recently, a reconsolidation that covers all three of those, the Greenhalgh's work, the Mickey work, and the Damschroeder et al. Work, published in Implementation Science in 2013 called the Tailored Implementation for Chronic Disease Checklist. They very deliberately did not want to call it a framework for a variety of reasons, but unfortunately what that's meant is when people do systematic reviews of the literature, they don't pick it up as a framework because it's not called a framework in their paper, which just shows some of the complexities of doing systematic reviews. But they actually had a very good point, because really the best use of these frameworks, determinants frameworks I'm talking about now, not the other kinds of frameworks, is as checklists and as ways to stop and say, are we covering all of the issues? I thought Jane did an amazing job of detailing some of the key things that interfere with implementation of QSEN and other evidence-based safety and quality practices in nursing and throughout healthcare. But I would say they're all hypotheses. And the point of doing the checklist work is to understand what it is that is really driving in that particular place the issues that you're facing. Why are people not interested in hearing new knowledge? Why do they resist doing things a different way? And figuring that out is probably the most important piece you can do in terms of the planning for making behavior change happen. So I'm just going to very briefly say that the TICD, which is the most recent reconsolidation, includes most of the major frameworks. It has 7 domains, and within these 7 domains, there are 57 constructs. And I'll just say that that is such a barrier for people right there, because they look at it and they go, 57 things I have to think about? Well, but on the other hand, it could be way more than 57. I actually have colleagues who say to me, the universe of reasons why things don't get implemented is probably infinite. And I have to say, as a pragmatist, I go, well, I can't handle that. Infinity doesn't work for me. I think that things may be large numbers, but still finite. And I think that the things that matter the most, the things we most need to attend to, probably are finite and pretty easily counted. But you do have to be willing to perhaps go up to at least double digits. And that's something that is hard to do. And I'll just say it increases the complexity of the work you do, it increases the time it takes, and it makes it much harder. Okay, I'm not going to spend much time on this because I'm running out of time, and you guys have been very patient, and we've got one more talk after me before you get to have a break. So I'm just going to say, so the real way that this works, and I think needs to work, is really systematically analyzing barriers and spending time doing that well. That requires qualitative work. It can require quantitative work as well. Depends a lot on the data you have accessible to you, the amount of energy, time, and resources you have available. So you use the determinist framework that makes sense to you, that will fit the best with what you're doing, to map those barriers to behavior change interventions, strategies, and techniques. And these have to be thought about both at the individual level, the level of the person whose behavior needs to change, and at the organizational level, because of those organizational constraints in which we all do our work. Because if you don't change the policies, if people say, I'd like to do things differently, but I can't because I'm not allowed to. So for example, if the medical formulary doesn't change and you want to prescribe a drug that's not on the formulary, that's an organizational barrier to your being able to get your work done. And if, as an implementation person, you don't deal with that organizational barrier, you will probably be missing the boat on an important piece. So figuring out how to put all this together, quite frankly, is still more art than science, but it is the science part that is developing rapidly, and it's the part I'm personally most interested in, so it's the part I focus on. But I think most of us would agree that this is an area where we do need a lot more research, and we need to be thinking much more systematically as well as creatively about how we can put these things together and have them cover the barriers and make sense. I'm not going to spend more time on talking about the implementation strategies, except to say that we now have several catalogs of these. So if you find yourself thinking, gosh, I wish I could think of a strategy that might deal with this barrier, there are places to look, and there are resources that will help you figure that out. Okay, I will skip through that. Behavior change techniques are a somewhat different thing, though, and these are much more individually focused. And in this country, we've had much less attention to them. This work has mostly been done in the UK and Europe, and hasn't, frankly, crossed the Atlantic very well. And it gets complicated again. There are 93 techniques that have been cataloged and put together in the behavior change technique taxonomy. These are, again, interesting to look through, and I would say particularly in the education side of what we do. As an educator, it would be worth looking at some of these behavior change techniques to try and see, other than lecturing people, what are the things we can do? And some of these are things we've used in nursing for a very long time. Modeling, shadowing, precepting, role modeling the change we want people to take on and what we want them to do. So, I'm getting pretty close to the end, which is good. It is complex to implement evidence-based practice, and the more complex the practices, which is typically true of any system innovation. Barcode medication administration, for example, was a very complex intervention. I think completely underappreciated as to how complex it was. And the implementation that it needed took a lot of time and energy as well. Dissemination is probably simpler, but I'm only saying that because it's not the area I work in. I think the issue with dissemination, the issue with dissemination is thinking about your audience is critical, and we don't do that very much. We really tend to think that everybody's the same, and we tend to have mental models that we're all like ourselves, but in fact we really aren't. And even your colleagues working with you in a school of nursing or in a unit may have very different ways of thinking about things. We have a lot of useful approaches, but at this point I would say they're mostly useful in the abstract and theoretically. I would really encourage people who are interested in this area to get engaged and get involved, and I would be happy to talk to any of you more about how to do that. But we need a lot more research, and we need research in particular within nursing, where it's difficult to get the platforms that you need because you need multiple units across multiple hospitals, multiple clinics, multiple settings, and you need to think about where nurses work and how they work. And the answer is it's so heterogeneous at this point that there's a huge field out there. So I will stop there. I think we may actually have a few minutes for questions, but as I said, we also will have time. I think there's actually a session later this afternoon that both Jack and I will be at, where I think we'll both be happy to answer questions, but if there are any quick questions now, please do feel free. Yeah, I think we've got 2 mics here.
Thank you. The ANA is working on a big project, a grand challenge, Healthy Nurse, Healthy Nation. And they're looking at some of the things that have been done in the past. Just if you think about seatbelts in cars, where when I was a kid, my dad would cut them out of the car. And now we're so concerned about seatbelts, and we really did change. So we know implementation happens. Do you use some of that also in a grand challenge to make these things happen?
Yes, that's a very good question and a really good point. And the answer is yes, people do. I personally don't, because my brain doesn't work at that scale very well. But there is a very strong argument to be made that if you can get a social shift so that it is no longer acceptable to put your child in a car without safe, adequate restraints. And that's a shift we actually have come to in this country. My husband and I watch old movies a fair amount, and you just cringe when you see this baby being stuck in the front seat of a car sitting next to mom or dad going like this. Because we know what happens if there's a crash. And that message has come through. Smoking has actually seen a huge shift in behavior. Those things, though, are very complex, and they cannot, I personally believe, they cannot be easily engineered. Now, having said that, large industry work does engineer it. And so this is part of the issue that I've, to be honest, had a little bit of concern about, that if we actually got good at implementation, that could actually be a very double-edged sword. But I'm not going to worry about that much because we're not very good at it, so it's not too much of a risk at this point. Any other quick questions or comments?
So thank you for that very interesting presentation and sharing with us these new methods and models for thinking about how we implement our competencies in education and practice. And I think that the message was that it's very complex, that there are these models that we can sort of think about and think about the concepts in these models to maybe give us some clues as to what kinds of behavior changes are needed in order to implement them. And then there's these strategies that may be effective too, that if we audit people and give them feedback, then they're going to change. And that if we incentivize them, they'll change or educate them better. So in reflection of that, can you share with us then, for your own experience teaching, and you had mentioned you were trying to integrate those competencies into your teaching, what kind of pearls would you give us in your last comments as to what you would use then in moving forward in your work, to implement the competencies?
Yeah, I think that's a really good question, and I'll just say I really did not do it well, so I'll just acknowledge that up front. And partly it was because it was a graduate course, and so we actually had no practice piece of it. It was a seminar course, and so we met, I think, once a week and talked about things, and really it wasn't very effective, to be quite honest. What was much more effective was in an undergraduate course where I was the clinical instructor. So I had a group of 12 undergraduates who actually had to do a QI project. Now, I will be very honest and say I did not use the QSEN competencies there, even though I should have, obviously. But that was much more effective. And I will say, though, that I think if I had sat down and mapped the QSEN competencies, I would have been able to say check, check, check to most of them through that process. But it was really that active process of engagement of students having to get out there, interact with managers, figure out what was going on in a clinic or on a unit, and solve problems. That was really the learning experience that made a difference to them and certainly made a difference to me. So I would say in education in particular, it is the active work. But that's also true in practice. The problem is, when do we get the space to stop and reflect on what we're doing and make that part of what we do? And I don't have any good answers to that except to say that we have got to keep trying to figure that out. So, thank you all very much.